I want to thank you very much for inviting me today. It's not common for a radiologist to actually see, the people on the outside that we're actually normally looking at. We see a lot of you, more of you than you can see, but we don't get to see your faces, very rarely. So it's actually a privilege, and to actually get to be with a group of people who are so completely dedicated to one fairly knotty but not insoluble problem. So I'm going to be talking specifically about CSF flow studies in Chiari. Some of you are probably very familiar with this topic. Some of you may not be. I'm going to try, I didn't realize I was going to be the very first speaker, so I'm going to try to give a little bit of introduction also to those of you who are unfamiliar with the imaging in Chiari as well. And I'm going to try to keep this fairly practical. If there are any questions, please. One thing I omitted was my email address at the end, but I'll happily give it to you if I'm not around for questions, but I will be around later. So, MRI, can we bring the lights down a bit? Because I think my slides are going to be impossible to see. Any way of doing that? Okay, well, in the meantime, you're probably familiar with MRI. With MRI, we can get the most really amazing anatomic images with some chemical specificity. I can talk about blood and types of fluid and fat. But for today's talk, I'm going to emphasize something else. But I just want to use this image to show you what we're talking about. Brain stem, spinal cord is down here. These are the this is one of the cerebellar tonsils. This is a normal brain. In a Chiari malformation, this little tonsil here is pushed down here into this black space, which should be just fluid. That's really it. And that has to do with the structure of the posterior fossa, the structure of this part of the skull. And that's what we're all here about, believe it or not. That's it. But that has implications for a lot of processes, and that's what we're going to talk about next. But aside from the beautiful anatomic images as we get from MRI, a lot of you may know this too, we can see flow with MRI, which is really amazing. You know how long it takes to get an MRI, what a clunky, slow machine, but we can get flow. And that's really amazing. This is an image from an arteriogram and a venogram. These are arteries, these are veins. This is showing flow. It's not showing contrast in a vessel. This is actually flow. This is using a technique called time-of-flight imaging, which is what we use for arteries and veins. Yeah, this is not going to be visible, I'm afraid. Is there any way to bring him down a little more? I'm sorry. So we can see flow in arteries and veins, which is not a surprise, but it is pretty impressive. But there's another space we're talking about today. Again, here's the brain. But surrounding the brain, sort of bathing the brain and filling the ventricles of the brain, there's a fluid space, the subarachnoid space and the ventricular space, and it's full of cerebrospinal fluid. And it flows too. But its flow is very different from that of arteries and veins. And to give you an idea, I don't know if you can see this. This is in red. This is a velocity waveform of an artery. This is the velocity of an artery going through the cardiac cycle. Every, ba-boom, ba-boom, ba-boom. And look how high this velocity is. It's going well over 100, 150 centimeters per second. It causes a pressure wave you can feel in your neck when you feel your carotid artery. That's what you're feeling. Veins have less of a pulse, but they do. You can pick this up. This is reasonable. Look at the size of the CSF flow velocity. These are tiny, tiny velocities. So it should come as no surprise that we can't use the same techniques to detect this CSF flow as we do for arteries and veins. And we use a specialized technique called phase contrast MRI. And with phase contrast MRI, which is we have to use a few tricks, but basically we're able to detect flow of the cerebrospinal fluid to and from the brain. And the nice thing is that we're able to detect not just the flow direction, but also its velocity. So we can talk about how fast it's going and in what direction. And just like the flow in the arteries and veins, it's pulsatile. It's not being driven directly by the heart, which is why the velocity is so small. Arteries and veins are being pushed, the blood's being pushed directly by the pump in your chest. This is very indirect. This is flowing because of all the arteries and veins around it. That's why it's such a small flow. But nonetheless, we are able to detect it using these specialized techniques. Here's the normal case. That's the same brain I showed you before. This is a very, I would say, inscrutable looking image, if you're not used to looking at them, and I have to tell you for some people who are. This is the kind of image we use. And I'm just going to call your attention. This is the same brain. This is the brain here. This is the brain stem. Here's the spinal cord, that gray with white on either side. And I wanted to call your attention to that white on either side. Because white is coding for flow going down, and that's what happens when your heart pumps systole. And black is going to be coming back up to the brain. That's when the heart relaxes diastole. And I'm going to try to run this movie, and we're going to cross our fingers. And you see how that white is turning black? It's going from white to black. It's going to make me do this a few times. White to black. You see it? So that white to black here, and it's going all the way up the front of the brainstem, and there's a little tail going up behind the brainstem, and that's because there's no impedance of flow. That's a normal brain with flow going up and down with the cardiac cycle. That's a normal case. So what can we use this for? Actually, a lot of things. It's used outside of Chiari and Syringomyelia for normal pressure hydrocephalus. This is heavily used. We use it to figure out what patients, these are elderly patients, might benefit from shunting. We use it sometimes for the evaluation of cysts in the brain to see if they're really separate from the cerebrospinal fluid or part of the system and then they have flow inside. Of course, we're going to talk about mostly with Syringomyelia and Chiari malformation, but I want to throw one thing out to the neurosurgeons in the audience. One other thing that it can be used for is shunt patency. Those of you know about shunts. These are tubes in the ventricular system when someone has hydrocephalus that help reduce the pressure inside the brain. And this is one case from the literature where actually they used this technique to show there's a tiny black dot where the tip of that shunt is, and that shows that flow is going into that shunt. That shunt is open and working. No one had to go in and do anything to this patient, just stick him on the MR for 3 minutes, and you know that the shunt is patent. So just throwing that out, it hasn't been used very much, and I have a feeling I know why. If there's any interest, someone should let me know, and we can try to talk to Siemens and let me try to make it work. I didn't say that. So in the context of Chiari malformation and Syringomyelia, there are specific uses for this technique. We can try to evaluate the flow, whether it's blocked, whether it's abnormal, in a regular Chiari malformation, and I'm going to show you an example of that very soon. It could also be used to evaluate for flow of abnormality when there's no tonsil descent, like I'll show you, which is called Chiari 0. It's a bit controversial, but the idea that you can have the same symptoms without having the tonsils down because the flow is still abnormal. So this is a very useful technique for that. It's very useful for follow-up after surgery. A lot of studies have been done in this domain to show that the flow that was abnormal changes, and you can monitor how the patient's doing over time after decompression. And it has a prognostic value, which I'll show you in a moment, especially in the case of Syringomyelia. So here's an example that I want to show you what we're talking about with Chiari. This is a Chiari malformation. Now, if you remember the earlier one, I showed you that tonsil was up here and there was black underneath. Here, this tonsil is oozing down all the way into that space. There's no black back here. There's no fluid back here. There's no room back here. That's a Chiari malformation. And in this case, I can show you what the flow looks like. You can probably try to guess, but you have the flow going in front, but look at the back. It stops. It stops right where that tonsil is sitting because the tonsil is blocking the flow. That's the kind of basic abnormality we're talking about with flow. Here's another example that I found in our series where another Chiari malformation with what was described at the time as edema, what now I think we would describe as pre-syrinx. It's not a true syrinx, but it's a little bit suspicious. You know it's abnormal. And in this case, at this time, we did a flow study. My mouse doesn't have any room. Oh, here you go. Flow study. And if you look, this one's going to take a few clicks. Again, there's flow in front, but stopping over here. So there's something abnormal about the flow. And in this case, 1 year later, the patient, let me just show you that. This is another way of looking at the same flow, by the way. This is an amplitude image. This is the same thing I showed you before. It may be a little easier to see because it doesn't show you the direction of flow, but it does show you where the flow is. See, it stops right here. Should, there you go. So there's no flow going behind the tonsil again. And in this case, 1 year later, this is before, here, this pre-syrinx, and now it's really developing into a real syrinx. And it's only 1 year, but there was abnormal flow. And there is a feeling that the flow abnormality is more predictive than the anatomy itself of whether a syrinx will develop. So one other thing to talk about here now is Syringomyelia itself. So here's a Chiari malformation with a sizable syrinx. So I want to call your attention this time not to behind, in front and behind the spinal cord, but where the star is, which is showing you middle of the syrinx. Because I want to show you there's flow inside the syrinx, and I'm going to show you how that looks in two ways. One, this is a little tricky, but you might be able to see it. There's a flash of gray right in the syrinx. One more. Here. And I'll show you on the magnitude image, you may find it easier. Again, the star is where we're looking, and there's white here. Just watch that white flash. I don't know if you can see that. You saw that white flash? That's flow inside that syrinx. Why do we care? Well, several studies have shown that, first of all, flow in the syrinx is predictive of the syrinx getting bigger. If you have a syrinx without flow or with very little flow, it may end up being stable. But if you have a lot of flow in a syrinx, it tends to indicate that it's going to get bigger. Second of all, other studies have shown that after decompression, even if the syrinx doesn't go away, the most reliable finding after surgery is that the flow in the syrinx decreases or stops altogether. And those are the patients who are doing well. So we can actually follow after surgery, look at flow inside the syrinx and use it as a predictive value for either before surgery or after surgery to get an idea of what may be coming ahead. But we can go further, and this is something I'd like to spend a little bit of time on. What I've shown you is all very qualitative, and it's very easy to do. You put the patient in the scanner for their MRI, you push a button, and you get those nice images. But I think we can do more, and this is what I'm going to be arguing for today. We can do quantitative evaluations. We can get numbers. We love numbers. I love numbers, and I'll tell you why shortly. And the way we do this is instead of taking the kind of image I showed you, we actually take a slice through one level. And the level is an issue, and we can all talk about it. It's a little bit controversial, but you take a level as close as possible to the foramen magnum, ideally, and we take a slice, and then we can do the flow studies in this slice. Now, I'm going to orient you here. It's a little bit harder to see. Brainstem, now we're cutting through it. And the white here you're seeing, and I'm going to show you over here, is flow of the fluid. So you're going to be watching this area of white over here, which is going to go white and black, just like the stuff I showed you before. White, black, white, black. That's normal flow. And that's doing exactly what you expect it to do. It's going up and down with the cardiac cycle. But what's so nice about doing it this way is that we can actually take a region of interest. We can measure the flow. We can't do that in the other way, but in this way we can, and get curves. Curves are great. Curves are numbers. This is diastole, this is systole. This is the heart beating, this is the heart relaxing, the heart beating. And this is the flow that's happening. We can give you a measurement now. A measurement of what? I'm glad you asked. Peak systolic velocity, for example. Why do we care about velocity? Well, because of the Bernoulli effect. You may have heard of the Bernoulli effect. It's a physical, it's a formula really, that describes what happens to flow. You have something flowing, like in a tube. Just imagine a tube full of any fluid, air, water, anything, flowing. But then you hit a narrowing. What happens? Well, one of the things that happens, according to the Bernoulli effect, is that the velocity goes up. So if you measure the velocity, if all you have is a velocity measurement, you can't see the tube, but the velocity went up, you know there was a narrowing there. Even if you can't see the narrowing, it was there. So this is very powerful. Because if you have a Chiari, what you have is a narrowing, because the tonsils have come down, they have blocked the normal space of the foramen magnum, and there is a narrowing. How much of a narrowing? Now we can give you a number. What if you have a Chiari, but there's no change in flow? Then maybe there's no problem there. What if you have something that doesn't look like much of a Chiari at all, but you have a velocity change? That could be a Chiari 0. But you need the numbers in order to say this. So quantification gives us a lot more flexibility and a lot more power. Peak velocity is really easy. That's the easiest one. I say that because that's something that even a relatively untrained technologist can get a good number. Relatively untrained. They need some training, but they can do this. They don't need the radiologist to come in and fiddle around. But I prefer to do a little bit more. I try to get velocity in specific regions because it helps us figure out how uniform the flow is. All it requires is additional properties which are specifically, we have to set something called the encoding velocity, which I'll talk a little bit about Don't be afraid, it's just a number. And we have to figure out where to measure it. But the encoding velocity is a very important value, and I'm going to spend a little bit of time on shortly because of this case. Here's the case. This is a Chiari malformation with a syrinx. This is pre-op. Post-op, a little bit of a collection, but look at this. Syrinx is completely gone. This patient is doing great. I actually know this because she said she's feeling fantastic, and she looks great. We looked at the flow for this case, and I'll show you what it looks like, if I can get my mouse back. Here. We did the flow, and there's this region in front where there's no flow. And I think this may have been read as sort of a block, because it certainly looks like there's something blocking flow over here. But I looked at this, and there were a few little telltale signs, which we can go over later, that told me I think that's not really a block. But with this image, I can't tell you anything. So we went back and did something a little bit different. And that's because incorrect settings can give you misleading results. And that's what I just want to talk about. Here, we're going to just talk about it, and this is because of a concept. Now, those of you who have any background in signal processing will know about this. If you don't, just pick up the word, because if you use it in the right place, it'll get you a better study. Aliasing. Aliasing is, again, it's something from the field of signal processing. The idea is this. The encoding velocity is something we have to plug into the MRI. It's a number. Actually, we don't have to plug it into the MRI, and that's the problem. The manufacturer plugs in the number themselves. And for some reason, like our machines, it's 6 centimeters per second. What that means is that we're going to pick up flow up to 6 millimeters per second, 6 centimeters per second velocity, up to that. That's what we can pick up. That's our sweet spot. That's what we're going to see. So here's flow. Let's say it's around 4.5. 4.5, it's great. We can pick up to 6. That's fantastic, which is great if your velocity is under 6. But what if it isn't? Like, for example, you have a Chiari malformation. Your 6 is not going to help you, and this is what happens. If you have a velocity that's abnormal, because that's why you're there, you get your numbers cut off. Your high numbers get wrapped around and come back as negative numbers. Your low numbers wrap up, come back as positive numbers. You end up with a curve that looks like this. You don't need to be a signal processing geek to know that this is just wrong. That's just not good. And that's not telling you anything real. So, with all due respect to our manufacturers, you have to be able to do something about this. If you set your encoding velocity, let's set it way high. Let's set it at 50. We'll never miss anything. Great. But then you're going to have tiny little signals that you can't get numbers out of. You see why this is a problem? The encoding velocity has to be set properly. If it's too high, we're going to lose the signal. If it's too low, we're going to misinterpret the signal. We may not even detect it. And it's a moving target. So if you have a normal brain, it'll be fine. But that's not why we come to get the MRI flow study. So someone has to be able to get there and say, okay, set the encoding velocity to 15, set it to 20, measure it here, set it to 20. It's not a lot of work, but it does take some involvement. And the reason for this that becomes even trickier, I promised my son I would show a picture from the Ausable River. He was fly fishing. I was bored. So this is the fact that when you have a narrowing, you get velocity increase, but when you have an uneven surface, flow becomes turbulent. Turbulence is worse than narrowing. Turbulence is narrowing on steroids. It's eddy currents that are going in huge velocities and then very slow, and it's a huge mess. You can imagine the curve on this would look terrible. So we have to know if it's a narrowing, if it's turbulence, or if it's a real blockade. So in this case, I went back, that case with the woman who had the surgery and had a very good response, went back and go to the quantitative study, and it's a little hard to see, but we actually measured it. There is flow. It's not blocked, but there is a little bit of flow up here. We're able to measure it, and it was at 17 centimeters per second. It's not infinite, and it's not 0. It's a number. Now, this lady can come back in a year and find out it's 12, or find out that it's 20, or find out that it's 2. But we can now follow her and know what to expect. But it's only if you know to change your encoding velocity from 6 to 20. So someone has to get in there and do it. Why should we do these quantitative studies? Well, what I'm trying to show you is that if you don't, If you just do these purely qualitative studies where you're just eyeballing it and getting a sense of whether, yeah, it's flowing, no, it's not, it can give you misleading results. You could think there's a blockade when there isn't. You could think a lot of things are going on when there isn't. It could be just turbulence because there's a little bit of a membrane somewhere. You can really misinterpret it. Quantitative studies are one way to get around that. But also, if you're going to take the time to do a quantitative study, it's really reproducible. You come back in a year, we use the settings, we can really compare year to year numbers, your numbers. And we can say, in all likelihood, something's starting to change now. Let's say you have a patient who has a Chiari, no symptoms, and you follow year to year, and this velocity starts to creep up. You can catch this before a Syrinx forms in principle. So this becomes very powerful. So in summary, just in combination with high-resolution anatomic imaging, something I did not really spend time on here, but which is worth talking about at some point, we try to combine these things so we can really see what's happening. We can see if there's a membrane. We can see if there's change of different types. We can, with quantitative CSF, we can really do simple, non-invasive, and this is important, commercially available techniques. This is not, you don't have to go to a research center. You can go to, a practice like ours. You can get the same study done, and it can be very powerful for prognosis, for diagnosis of Chiari and Syringomyelia. With that in mind, I just want to shift gears because when I was preparing this, and my previous life, I was a basic scientist with an active lab. So I start with the literature, and I start with PubMed, which is where I'm most comfortable. And I start looking at the literature, I'm thinking, wow, that's all, huh? So I actually went in and counted. I went and counted all the papers dealing with this technique. Cine, it's called Cine MRI, Cine because it's like a cinema, it's like a movie, right, that I just showed you. And looking at it from the time it was really introduced in 1986 to the present. And you see there's been an increase in the number of studies per year, but this is not a lot of work. This is not a lot of stuff. Most of this is done by people who have addressed this very meeting. You probably know, for the Chiari ones, you probably know almost all the papers in here. And this is including cases for normal pressure hydrocephalus, arachnoid cysts, depression, dementia. People do this for all kinds of things. Ventriculostomy shunts, all kinds of things. All of the papers are here. To give you an idea of what it should be like, I'm going to compare it to another technique developed around the same time you may have heard of called functional MRI. This is what happened with functional MRI. It's going through the roof. This is a typical curve for a new technique that becomes commercially available. So what's going on here? Why is it not being used more? This is not just research, this is also clinical. Why isn't it being used more? So I don't know. The answer is I don't know. I have a suspicion though. Availability is not really a very big deal because it's only just software. It's expensive software because it's coming from commercial, it's GE, Siemens, and Philips. But it's fairly available. You don't need special equipment really. Insurance I can't talk about because I don't know. And now with everything changing, I really don't know. But it seems to be something that gets covered, so I don't think that's it. I think there are sometimes concerns for patient comfort, which I'm going to address in a moment, because for many of you, you may be worried, what are they going to do to me? I'm going to tell you what we do to you. It's not bad. And I think this is the real problem, is that all the stuff I told you about that encoding velocity and having to get someone to put in a number, ooh, it's scary. It is. It is. It's intimidating. And I'm going to talk about that, and I think that's the real problem here. In terms of comfort, just so you know, though some of you may have had these, how many of you have had any of these studies? Has anyone? 1, 2, yeah, okay, that's not bad. That's really not bad. It's just added to your follow-up MRI. If you're getting regular MRIs, you're just lying there, you're just gonna lie there a little longer. We have to use cardiac gating. Remember how small that signal was? We cannot pick up a signal that small as long as you've got arteries and veins doing this all around. You're gonna lose it. We have to silence the arteries and veins, and there's only one safe way of doing that, and that is with cardiac gating. So you wear an EKG, or actually most commonly just a pulse ox. You all have seen one of these. It's on your finger. This is not a big deal, okay? And you just lie there. How long does it take? Good question. About 3 minutes for that sagittal, the qualitative, the eyeball view, about 3 minutes. 3 minutes also for the quantitative one. The holdup there is, of course, if you need your encoding velocity reset a few times, you may have to repeat it, but each time it's 3 minutes. I know it's a long time once you've been lying there, but it's not all that bad. No one's putting any needles in you. We're just asking you to hold still a little while longer. The numbers we get offline. We don't leave you in the magnet while we sit there fiddling with our numbers. We do that, you're home already, okay? So it's not that invasive. It's a little bit inconvenient, but you're already there for the MRI, and frankly, all those other sequences are much, much worse in my opinion. They're louder too. So what can we do to optimize this? Well, this is where it gets a little, this is where you have to, talk to us, and that's good. I think there's a certain frustration on the part of the clinicians who order this, the surgeons and the neurologists, because sometimes our reads may be a little bit, well, we think there's a little bit more flow, less flow. That's probably going to be very annoying. So to avoid that, we have to do a better job on our imaging. And I can tell you personally that quite a few radiologists that I know, even neuroradiologists, are intimidated by this technique. So everyone's afraid. There's nothing to be afraid of. What do? Call us. We're so lonely in those rooms. Just call. Tell your doctor, please talk to the radiologist. We're pitiful. But call us, we'll talk. And we'll figure out what should we do. Do we want to get numbers? We may not need numbers. Is this a first diagnosis? We want to know if there's a Chiari, then we may not need this at all. Do we want to see if there are numbers where? Has the patient had any surgery? What are we looking for? Is there a syrinx? Do you want to see if there's flow in the syrinx? It's a little dialogue. And most important to me, figure out if one of the radiologists should be around for the study. I'm sort of a helicopter, that's the way I'm a mother to it, it's sort of helicoptering. So I'll often helicopter in the control room and say, oh, change the vanc, and then I walk back and we read it later. But that's something we need to figure out. So instead of a script like this, and I can tell you right now that at the August institution I was at in the past, if you put in a script like this, MRI with CSF flow study 9 times out of 10, no matter who you are, you would walk out with a CSF flow study for normal pressure hydrocephalus, even if you're a 17-year-old kid, and that's a study for an 85-year-old man. Because that's what we do most often there, and that's what the technologists do. But if you put in a script like this, it's a little wordier, MRI, CSF flow study, quantitative, if possible, right? Known Chiari 1 malformation. We already know now we're not looking at the aqueduct of Sylvius high up, we're looking at the foramen magnum where the Chiari would be. No prior surgery, very helpful information. There may be a syrinx. We want to know if there's a syrinx. If there's a syrinx, we want flow. And look at this, attention radiologist. If you do that, you're going to probably get a radiologist to look at this first, review the films, get an idea of what really would be the best study for this patient. I think if we do this sort of thing, the communication is the most important thing here. We can really try to get the most out of these studies, and I think there's a potential to get a huge amount out of these with relatively little inconvenience to everybody. Okay? That's it.